Thank you for inviting me to be part of this important conference. I'm happy to be giving the next lecture in this series about the experiences of LGBTQ people with cancer. Today, in addition to briefly reviewing why it's important to know patients are LGBTQ and to know about what disparities these patients are experiencing, we're going to talk about what we can do to promote equitable cancer care for LGBTQ plus patients and their loved ones. In oncology, it is always our goal to provide patient-centered care, and this has many moving parts, one of which is providing equitable and team-based care, as shown by this patient-centered cancer care model from American Society of Clinical Oncology. To do this, we must provide high quality, equitable care across diverse populations throughout the cancer care continuum. So from prevention through survivorship or end of life, with our palliative care services, with patient navigation, with distress screening, with all of these moving parts, we need to be providing high quality care. What's true, however, is that LGBTQ plus Americans get worse cancer care, and that is across the entire cancer care and cancer control continuum. From prevention, we see with minority stress, higher rates of smoking. We see little education about the cancers that LGBTQ people experience at higher rates, such as breast cancer related to obesity, anal cancers related to HPV. And in general, because providers are not engaging with patients, we see lower rates of screening. And screening really, not in general for cancers, not just LGBTQ specific cancer screening, using the anal cancer example. In addition, traditionally, when we're dealing with trans people, so if we have a trans female, so someone who was assigned male at birth and then transitioned to a female identity, that person will likely retain their prostate. And what has happened is that in the past, up until recently, cancer screening would not have included prostate cancer. And if somebody's diagnosed with prostate cancer who's trans and has a female identity legally, treatment would not be paid for, diagnosis tests wouldn't be paid for, and people went with treatment. Another barrier to screening is that screening takes place in gendered settings. So to ask somebody who is male with breast cancer, whether that person's cis or trans, to wear a pink robe in order to get a mammogram can be very off-putting. In addition, LGBTQ people do not see themselves in traditional screening campaigns. And as I said, this is reflected in part to how their primary care doctor treats them, with lower rates of cervical cancer screening, for example, for people who identify as lesbian, and yet there's not really an intake about what that person's behavior or risk may really be. There is delays in diagnosis and in care, part of which is related to being underinsured as a community. When treatment is happening, there's fewer support services offered, including fertility preservation, and there's unanswered questions that we need to know more about in order to accurately and safely provide care. For example, if someone is transgender, is on hormones, is male presenting with those hormones in place and gets lung cancer, if they're getting carboplatin, which gender do we use? If we're interpreting labs, which gender do we use? These answers are really unanswered. These questions are really unanswered and yet are crucial to treatment and are things that are being investigated and studied in order to provide best practice recommendations. But because of this, people are getting worse care. What we see in survivorship is more reports of sexual dysfunction, more distress, higher rates of anxiety, less likely to follow up. And it's really understudied what the long-term side effects, including sexual side effects, are for LGBTQ people. In end-of-life settings where it's particularly sad, if people cannot be out and disclose because they don't feel safe, there's a fundamental issue with respecting a person's dignity. And really the question of whether or not the right people are at the bedside, because if we go to the family of origin and the patient's estranged from them, we might not have their most trusted people with them. This in particular, the discrimination that happens at the end of life is an area of research that I've been involved with. This is one of the papers, and I just want to mention it because it's very sad what we found, which was that even at the end of life, people are being ridiculed. People's loved ones are being kept from them. People are being treated roughly and with disrespect at a high rate when they're LGBTQ, even in hospice and palliative care settings. So besides wanting to address these disparities, why is it important to know your LGBTQ patients? Partly because there's a lot of us. The latest census data shows that 7.2% of the population identifies as LGBTQ. And when you look at the population 30 years and younger, that is as high as 15%. And so despite what providers think, because about 63% of providers think that they are not seeing LGBTQ patients, the fact is if you have 100 people coming through your center in a given day, you have at least 7 to maybe even higher number of LGBTQ people coming into your center. They maybe do not feel comfortable disclosing, but data actually shows that about 93% of our LGBTQ patients, if given the opportunity to disclose their identities, will. This, of course, varies by age and increasingly by state, because there is a surge in fear about discrimination. So one of the things is that even though patients want to disclose, we often don't ask. And rarely when we look at the research, it's not that we're asking because as oncology care providers and part of the oncology workforce, we're overtly discriminating or even uncomfortable with LGBTQ people. So it's rarely that we're uncomfortable. So why aren't we asking? One is that we don't know what's important or relevant to care, but hopefully, as I just went over, it is important. We don't know if patients feel safe. We don't know if patients. So what this really means is that historically, we've thought that we've been doing harm by asking people if they're LGBTQ. This comes out of a tradition of and a history of discrimination, and a history of discrimination within medicine. Within people's lifetimes, lobotomies were routinely done on LGBTQ people. And so there is this tradition and this history of assuming that patients do not want to give us that information. And yet in oncology settings, a very high rate of patients given the opportunity to disclose will. We don't have the training on how to ask in a respectful manner. And so while we're comfortable with LGBTQ people, we're not necessarily feeling knowledgeable or comfortable with our skills. And I think along with not knowing if it's important, we don't really understand the experiences of LGBTQ people and patients. And part of that is that there is a huge disconnect when we look at the literature between oncology providers and oncology workforce feeling like they're trusted and there's no barriers, and yet LGBTQ patients are reporting feeling very uncomfortable. As much as 43%, as many as 43% of LGBTQ patients with cancer report feeling very uncomfortable in oncology settings. There's a high rate of mistrust based on discrimination that's previously experienced. And even though we may feel it's not our fault, we are part of institutions, which we'll talk about, but we have to meet patients where they're at. And if patients are particularly afraid and particularly worried and particularly anxious, we should know that so that we can take better care of them. So the good thing is that there's education and resources to address a lot of these issues. Just the fact that we're having this lecture today. So what's important is that we do not need to keep our LGBTQ patients in the closet. It actually does harm to not allow patients the opportunity to disclose and to not have a safe environment where people can disclose. It elevates people's care, it decreases their anxiety, it makes it more possible to connect with their loved ones and caregivers. And we miss an opportunity to know our patients if we assume that we are doing harm by asking. Also, by not asking, we're reinforcing that it might be shameful to ask. And so we're amplifying stigma and ignoring high levels of distress and discomfort and mistrust. The discomfort and mistrust are earned. Their discrimination is real. Implicit bias and assumptions that we make in settings are real. Minority stress and the negative impact on people's health is real. And so we're missing opportunities to provide equitable cancer care when we don't provide an opportunity for people to disclose their sexual orientation and gender identity. What's true is that we've inherited structures and institutions that discriminate. And this picture here shows someone who's a lamplighter. This person used long poles to light and extinguish and refuel street pumps before electricity was available. This is not something that we need anymore. And we can change things that are obsolete, and we can move forward in medicine. So the thing is, what can we do? What can we do when we have structures that render LGBTQ people invisible, that make it hard for us to understand that they're mistrustful when they come in because of all these prior lived experiences, and because when they walk into the center with their wife of 40 years, people assume that it's their sister and do not provide that person with the respect that we would normally have a spouse. So what can we do? We can listen, we can try to understand people, we can advocate for them, and we can ask open-ended questions. We can also do work to address our implicit biases. And although this book is on hospice and palliative care, this is a wonderful book that really talks people through their LGBTQ biases and assumptions that they maybe weren't even aware that they were making. And so I just wanted to recommend that. The other thing we can do is collect sexual orientation and gender identity data. We can learn how to ask. We can ask our institutions to collect this data. And one of the interesting things in recent research is that often, if you have a robust EMR, if you're at a bigger institution, patients are disclosing, they are putting their sexual orientation, they are putting their gender identity. There are fields to do that. And they're reporting about 90% in oncology settings of filling this data in. And yet, when we ask providers, less than 30% know where to find this information in the EMR, and even fewer know how to use the information to provide better care. Also, if you're a researcher, collect the data, because having data on everybody that actually reflects their experiences moves the field forward and lets us answer fundamental questions about how to better take care of LGBTQ people. You can familiarize yourself with resources. Here's a number of resources, and you'll have access to the slides. I want to point out two particular ones. ASCO has just opened up, it's a very wieldy website address, but it's an excellent site. It has resources for clinicians, it has resources for researchers, it has resources for institutions, and at the bottom it has resources for patients as well, including referring to several of the resources that are listed here. The first two are really online forums. National LGBT Cancer Network has done online support groups and other programs for screening. SAGE is a great place to go. One of the things that's encountered by trans people with terminal disease or who are dying is they may have their family of origin come in and bury people in their in the gender of their origin, so from their birth name and not their chosen name. And so there's forums on how to address things like that. In addition, there's a toolkit that's being released by Prime Education on August 1st that will have great resources. You can also partner locally and create your own resources, such as survivorship education, like a seminar for LGBTQ people in your clinic, support groups, bereavement groups. have welcoming literature in your library and in patient-facing areas, and publicly show support for the LGBTQ community and pride events, which happen all around the country. Engage your leaders and challenge them with these questions, particularly about SOGI data collection. Is it comfortable for patients to disclose? Do we give them a place to do that? Do we know where to find this information? Do we know how to use this information? Are we talking about these things? At this moment in time, advocacy is particularly important for LGBTQ people in healthcare settings. There's a lot of gender-affirming care bans and a lot of back and forth that's really causing a lot of stress and distress for patients. And so to be out there as physician advocates and leaders, I'm sure that's why you're doing this program, and it would be really important to have you include LGBTQ patients in your efforts. Thank you, and I look forward to talking more about what we can do.